And so what happens then is you get a very rapid repair of the epithelium, but then the pockets of bacteria still hiding in the epithelium.
Today we're talking to Dr. Soman Abraham, who is the Grace Kirby Professor of Pathology at Duke University, and we received a lot of requests to interview you about the UTI vaccine that you're working on. Can you give us a little bit more information about your background and how you came to be working in this space?
Well, thanks, Melissa. So I have been working on urinary tract infections for close to 30 years. I actually started working on that when I was a PhD student in Newcastle upon Tyne in England. And since leaving the UK, I came to the US and I've been working on various aspects of the infection. Initially, I was focusing on just the bacteria and trying to identify components of the bacteria that could be used as vaccines. And more recently, I've been looking at the immune response and have discovered certain unique aspects of the immune response, which could explain some of the pathology associated with urinary tract infections.
Okay, great. So maybe first you can give us some insight into why the immune system struggles in the first place to clear urinary tract infection and why it becomes chronic in some people.
Yes. Typically what happens when you have a urinary tract infection is bacteria get into the bladder through the urethra and then multiply in the urine. And then they after a while, bind to the surface of the bladder epithelium and then invade into the epithelium. And then that's how they initiate the infection. And often the bacteria can also grow within the epithelial lining, right? So that's typically what happens when you have a urinary tract infection. That's the initiation step. But then what then results from that infection is that the epithelium tries to get rid of the bacteria. And so what happens is the bladder lining tends to shed. In fact, that's quite intense, and it's fairly unique to this organ, where essentially the entire lining of the bladder is shed during urinary tract infections. And when that happens, there's a massive reduction in bacterial numbers. So that's the way that the immune system tries to get rid of the bacteria initially. But then there's a downside to that, and that is the underlying tissue now becomes exposed to the urine and the contents of urine, including ammonia, salts, and so on. And often that exposure is the reason why a patient goes to see the doctor. There's a lot of pain, intense pain, because of that exposure. And that actually results, okay, let me back up a bit. So typically, to repair that epithelium, the host cell sends in an immune cell type, which has largely been overlooked in the bladder up to now. And that immune cell is called the T cell. And typically, two types of T cells flock into the bladder following infection. One is to repair the epithelium rapidly, and the other is to kill off any residual bacteria that's there. Now, because of the intensity of the pain and the requirement for rapid repair, what the bladder does is it sends in mostly the T cells, which are called Th2 cells, that are proficient in bladder repair. Often this is at the expense of the immune cells that are important in clearing the bacteria. And so what happens then is you get a very rapid repair of the epithelium, but then the pockets of bacteria still hiding in the epithelium that remain, and they can then give rise to another infection. So it's this residual bacteria that are hiding within the epithelium that give rise to recurrent UTIs, and often this could also be leading to chronic infections. So that's the unique aspect of the immune system that predisposes to urinary tract infections. So most times when we have an infection, particularly in healthy people, you would get immunity to the infection and therefore be protected against subsequent infections. But in the bladder, what is happening is that every time you get infected, you get more of the Th2 T cells coming in to repair and less of the Th1 cells, which are directed at killing the bacteria. So in essence, what happens is with every bout of infection, you come even more predisposed to another infection because there's still pockets of bacteria remaining. And with every bout, you come more and more proficient in repairing the epithelium and the bladder, and less proficient in clearing the infection. And that's why you have this chronic infection that occurs when you have UTIs.
Does that mechanism also help explain why antibiotic treatment is often ineffective in that case?
Yes, it's a good question. So a lot of the bacteria that are hiding in the epithelium are found within epithelial cells. So they're hiding inside. So when they are inside, the antibiotics, when they apply, kill off all the bacteria outside the epithelium cells. So they kill off all the bacteria in the urine and all the bacteria attached to the surface of the epithelium. But the bacteria that are hiding within are also not cleared. And that's why you have these antibiotics being largely ineffective.
Right. So we are aware that there are a few UTI vaccines that are available in some countries. Can you explain how those work? And then we can talk more about how your new approach is different.
Yes. Okay. So there are a number of UTI vaccines, more in Europe than in the US. I think one is called Urine. This is where I think they get the collection of different bacteria that have been implicated in urinary tract infections. They kill this bacteria, and then these are then applied underneath the tongue, and it's sort of called sublingual immunization. So that's one form of vaccination. The idea being, if you stimulate the immune system of the mucosal surface, you would get IgA antibodies, and potentially this could be against a whole range of bacteria. So that's one. There's another one, I think, called Solco Urovac, which is kind of, this is a different kind of vaccine where they use 10 different heat-killed E. coli strains, which have been implicated in urinary tract infections. These are all absorbed into a vaginal suppository, which is then applied to the patient. And the application is for, I think, 14 days or so. So that's a different kind of vaccine. There's another one, I think, called Eurovaxom, which involves a bacterial extract, which is made up of, I think, 18 different urinary tract E. coli. It's an extract, and then that's given orally. And often that has to be given, I think, once every day for 3 months to get sufficient immunity. So these are all current vaccines. And then in the US, there's a company called Sequoia that is now testing a vaccine composed of FIMH, which is the protein on the surface of E. coli that attach to that induce the bacteria to attach to the walls of the. Very similar to the S protein on COVID, which is also used to induce the virus to attach to our cells. So this FIMH, this vaccine is comprised of the FIMH protein, which is then mixed with an adjuvant, which is a immune enhancer, if you will, and that's then given as an intramuscular injection. So all of these are meant to induce antibodies in the body, most of the time in the circulation. And in the cases where the vaccine is given orally or sublingually, you would also get antibodies in the mucosal secretions. secretions such as saliva, as well as the mucosa of the bladder as well. So the thinking is you would get antibodies at these sites as well as the blood. So how is our vaccine different? So from what I kind of indicated, a lot of the bacteria that persist in the bladder, or not all, but perhaps a significant number are actually found inside epithelial cells. So by inducing antibody production against those bacteria, they really cannot clear those bacteria. Those vaccines are very effective in clearing all the bacteria lining the bladder, as well as any bacteria that may have got into the circulation and elsewhere. But they are not effective against those bacteria that are hidden inside the epithelium. So our vaccine, as I said earlier, is will be directed against the bladder epithelial cells that harbor the bacteria. So I mentioned earlier there were two types of T cells. There's Th2 and Th1. Th2 is focused on repair. Our vaccine, and then Th1 is meant to attack the bacteria as well as epithelial cells that harbor the bacteria. So our immune vaccination is directed at going after bacteria hiding in the bladder, including the cells that host the bacteria. So by killing off those cells, you would also eliminate the bacteria. And so what we're doing is we are introducing our vaccine antigen, which in this case is the FIMH protein that I mentioned earlier, but we incorporate an adjuvant, which is very potent in attracting the Th1 T cells, the T cells that are important to clear bacteria. So what we've done is we combine the FIMH vaccine along with this adjuvant and apply it into the bladder. So when I say into the bladder, this is very relatively easy in females, where you introduce small amount of the vaccine using a catheter through the urethra, and then the fluid is introduced into the bladder. And then if the subject holds on to that fluid, and it's a small volume, for 1 to 2 hours, that's all they need for that subject to be vaccinated. So
does that mean they only need to have one dose then, or is there multiple doses over time?
I was coming to that. So we need to give 1 injection and 2 boosters, so a total of 3 challenges. And when that happens, what you end up having is you would get much more Th1 T cells coming into the bladder. And so in addition to the antibodies that will be produced, which is the case with other vaccines, our vaccine is uniquely beneficial in that we bring in these Th1 cells, which the other vaccines don't do. Ours will, by applying it into the lumen of the bladder, we are able to educate the immune system to come to send T cells from the circulation into the bladder, which is where they are needed. So it's very important that we apply the vaccine into the lumen of the bladder. And again, this will be much more applicable in females than in males.
Okay. Is it possible to use it in males though? We did get that question.
Yes, it is usable, but then it's much harder to introduce it in the male urethra. The female, it's very relatively easier and much less painful, I suppose.